Thank you everyone for coming. We're getting started. So thank you for coming to the Structural Competency, New Responses to Inequity and Discrimination in Health and Welfare Conference. So we have people from all over the state and from out of state who've come today, and it's exciting. I want to thank the sponsors and co-sponsors, and I'll read them quickly, although you can see them also. It's sponsored by the Berkeley Center for Social Medicine, the Berkeley School of Public Health, Samuel Merritt University, co-sponsored by UCSF Global Health Sciences, the School of Social Welfare at Berkeley, the Health Equity and Diversity Cluster of the Haas Institute for a Fair and Inclusive Society, the Diversity, Inclusion, Community, and Equity Committee of the School of Public Health, Radical Medicine, the Students for Racial Justice, Inclusion, Diversity, and Equity with funding from the UCB Graduate Assembly. So I'm going to ask all of you to turn off your cell phones. With all due respect to the anarchists among us and inside me, I'm also going to ask you to raise your hand if you're going to vote or already have voted. And I'm going to ask you to raise your hand if in some way you're going to work to get out the vote. Okay, great. So I'm now going to introduce Stefano Bertozzi, the Dean of the School of Public Health, who will give you some more welcoming comments.
Thanks very much, Seth, and welcome indeed. It does feel like I'm in a little bit of a twilight zone here, I confess. We've had a number of corporate CEOs over the last months giving talks in dingy, horrible Wheeler Hall, and we're having the structural competency meeting in the ballroom with crystal chandeliers. So. But the other thing is, before Seth said what he said, I have to say I was sitting there thinking that it's a little bit strange today, which is, 4 days away or 5 days away from Tuesday, that all of us are here rather than calling Florida. And it feels a bit strange to go home addicted, as I suspect many people in this room are, to watching or can't look away from what's happening nationally, and then to come back here to talk with people who are, I suspect there's nobody here who's not reasonably like-minded, while these titanic things are happening at the level of the country. And for those of you who watch Europe closely, very similar things happening in much of the rest of the world. And one of the things I struggle with, and I'm going to be very interested to see what comes out of these discussions, is how do we take what we do in our world and have it relate to what's happening in the world that I suspect we don't understand? Because I literally do not know a single person well enough to have a conversation with who's going to vote for Donald Trump, which for me says what an incredibly isolated world I live in. And I don't know how many of you, for how many of you that's true. But what I love about the horrible things that are happening around us, from Black Lives Matter to this election, is that it is creating energy around what's happening here. And I don't want to even call that a silver lining, but it is very gratifying. It's very gratifying to see what's happening within our school, within our campus, within the broader community of engagement that I would say certainly for many people had waned after the election of our current president, and a thinking that we were on a better path. And so I think that this is incredibly timely. I'm incredibly excited. I can't believe the turnout and the number of people who've RSVP'd for this event, and I'm very grateful to Seth and all the people who've worked with Seth to make this happen. So thank you. It's my great pleasure to introduce one of Berkeley's foremost scholars and expert in this area, Nancy Scheper-Hughes, who is a Chancellor's chair of medical anthropology, and not only a leading intellectual on this campus, but also a leading expert globally on the issues that this conference is about. And she's going to introduce our keynote speaker and tell you about what we're going to hear from her. Thank you again for coming. Welcome to Berkeley, and I look forward to all that I think and hope and expect will come out of this conference. Thank you.
Hi, this is fabulous. I guess it's at least 4 of these big conferences, and it's just growing and growing. It's really what it is a social movement. And I'm really delighted to be here to introduce Helena Hansen, say a few words, too, about the way in which cultural competency emerged and its various partners, as in RadMed, which is one of the projects that we've been working on for the last few years with the help of the University of California Humanities Research Institute, which gave us a 2-year grant. So Helena is a rising star in this social, medical, political movement in the United States that we call, some of us like the word, some of us don't, structural competency. She's a professor of psychiatry and anthropology at New York University. She earned her MD, PhD in cultural anthropology as part of Yale University's NIH-funded medical scientist training program. She's a joint appointed assistant professor of anthropology and psychiatry at New York University, a research psychiatrist at the New York State Office of Mental Health, Nathan Kline Institute. She began really, really early doing brilliant research. During her graduate school years, she conducted fieldwork in Havana on the Cuban AIDS policy, which I did as well and got into big trouble for trying to explain that it wasn't quite quarantine that was going on and that we had to understand what was happening there in the context of the the Cuban political economy. But what an important topic it was for us. But she's also worked in Connecticut on harm reduction and needle exchange, in Puerto Rico on faith healing and evangelical Christian addiction ministries run by the ex-addicts themselves. Her work has been published in clinical and social science and anthropological journals from the Journal of the American Medical Association, Health Affairs, Culture Medicine and Psychiatry, and Medical Anthropology. She's probably now, I think, at least among my students, most known for her work on the opioid epidemic and on the where she has conducted for a few years now this study of an ethnographic study of addiction via pharmaceuticals and the way in which the political attempts of clinicians to establish addiction as a biomedical rather than as a social or a moral condition was also contradictorily, in a sense, involved, of course, in a biomedical neurochemical treatments that she has argued may be reinscribing hierarchies of ethnicity and race in the United States. So Helena, along with Jonathan Metzel and a coast-to-coast today cohort of physicians, ER, health workers, community psychiatrists, first responders, community activists, hospital chaplains, medical students, medical anthropologists, is a leader in what I'm calling a kind of a quiet revolution to radicalize medical practice beyond the current paradigms. And to do so not only in the hospital, not only in the clinic, but on the streets, in the prisons, in the schools, and other institutions in America. Now, this tradition that is being renamed I would say cultural competency, because that's the one that this is overriding, expanding from, but it does emerge from, obviously, social medicine, Virchow, the work of Antonio Gramsci, Foucault is in here, the many movements in radical psychiatry. Wouldn't be myself if I wouldn't say democratic psychiatry of Franco Basaglia, and also influenced by civil rights, human rights, and by the notion of an injustice that goes beyond the norm, that some things that happen in the name of medicine can be seen as crimes against humanity, and we don't have to go back to the Nazis to do that. So I think it can be a very, very powerful instrument. So what is structural competency trying to do? Most medical practitioners are people of good faith, not bad faith, in the Sartre tradition. They know that something is terribly wrong. Something is amiss with our fragmented, inadequate, inequitable, and in some cases deficient medical, psychiatric, healthcare system. But what I think this group that has been working together around this concept has found is that even though you know things and you feel it inside, you may not have a vocabulary. You may not have a set of concepts, keywords, in Ray Williams' sense. What is it we're missing? What is it that we're taking for granted? What is it that gets normalized? What is it that becomes invisible? And so it does grow out of also many studies on structural violence. And structural violence actually goes back pretty far, and everybody has a different genealogy, but I believe it came from Brazil, from liberation theology, where the little red archbishop, Don L. de Camara, I can remember face to face when I had to get his approval, or I wanted his blessing to do my return work in northeast Brazil on hunger and on infant mortality. And he said, I will give my blessings, but only if you study hunger. And he said, there's the balm of poverty, there's the violence of hunger. And so he was already giving me words, this little archbishop, to understand structural violence, which I think is so important. So what we need and what I think is being done here and will be done here today is the formation of not only a radical curriculum, but a radical pedagogy, one that is able to make visible what is invisible, to make legible what's illegible, and to have ways of confronting what I sometimes call everyday violence, bureaucratic violence, institutional violence, and also betrayals. When medicine doesn't work right, it's a betrayal. So what this, I'll just say briefly again, what I think this structural competency is to determine under what circumstances people are likely to get sick, likely to break down, fall apart, die prematurely, die unnecessarily, and on top of that, to suffer the double of the diseases that they already have. Diseases of organ failures, of medical conditions that carry this double of stigmas, indignities, attached to sometimes unthinking and toxic categories of the psychotic, the addicted, the obese, the ignorant, the ill-formed, and somehow leading back to the individual and being their own worst enemy. So anyway, just want to say that we're going to have, the other concept I want everybody to pay attention to is this notion of a kind of a humility or a modesty in what it is that medicine can do. And I recommend to everyone a book that I've been teaching for at least 25 years, John Burge's wonderful book, A Fortunate Man, about the Dr. John Sassel in Britain, who was trying so hard to be a doctor not only to his patients, but a doctor to society, a doctor to the body politic, and he couldn't do it. So there is this problem of taking on so much that you actually collapse, and which is what happened with Sassel, who committed suicide when he began to see that he couldn't be a revolutionary, he couldn't be a politician, and he couldn't be a doctor at the same time. So in our discussion group, I'd really like us to talk about the limitations, what can be done, and what may be very difficult to accomplish. And so there's a poster, many posters on the back. We're having emerging epidemics, Ebola, Zika, and chikungunya, that will be looking at the new xenophobias that enter through disease. It's an old story, and it'll be on Monday, November 21st. in Krober Hall, the Anthropology Department, second floor. If anybody is interested, the RadMed people, have started a new food insecurity task force. And if anybody is interested in that, we're talking about the homeless in the streets and the homeless in the university, the hungry people in the streets and the hungry people in our university. We have many, many students. I think you know, those of you who watch TV, that we have students that are being fed in the basement in a hidden place you can't even find, a pantry where they can get peanut butter and salmon and bread and whatever. And so we really want to confront not only that, one last thing that I think is a shame in all of the cuts, which does not include, as we know, administrators and SUE administrators and chancellors, vice chancellors, and the vice chancellors. What is being cut is the rations for people, our students and undergraduates who pay in the university food halls to be fed. And they are limited to 2 meals a day and 6 days, not 7 a week. So that is structural violence by people who have 5 martinis and 6 meals and complain about all the meals because they have to talk to so many people. That's it.
How many structurally competent people does it take to set up the PowerPoint? Wow, what an honor to be introduced by Nancy Scheper-Hughes. I can't think of anyone who both takes on the intellectual work of understanding social life, health, and bodies to the extent that she does, to the level that she does, and also is so engaged with work on the ground with people like ourselves. So it's just really an honor. And actually, she was probably the first, if not almost the first, medical anthropologist that I read in my youth. Her work on AIDS in Cuba really informed my own field work. So anyway, I'm really thrilled to be here among friends and like-minded people. It turns out I don't have to start my talk by arguing for the social contribution to health outcomes that overwhelms the biotechnical contribution. I don't even have to define structural violence or introduce that concept. So this is really exciting. And it's also nice to be home. I'm only a few blocks now away from the hospital of my birth, Alta Bates. And being home has made me reflect a little bit. How did I get obsessed with importing social change into medical training? It might seem obvious that that's the way to go, and at this stage of my life, it seems as though there would be no other way to go. But I also realized that I have a much more specific emotional attachment to this project. I grew up in West Berkeley, near San Pablo, before it was gentrified, while it was still low income and semi-industrial. And I remember in grade school learning to run from the bus stop home because the streets were just crowded with people who were muttering to themselves, some of them cursing. And they'd been threatening to me too. What I didn't know at the time was that the state mental hospitals had closed most of their beds at the same time that community mental health was not funded. And also suddenly my uncle became a part of this picture, showed up at our doorstep in a psychotic state. And he eventually died in one of the few mental hospital beds that was still open, state mental hospital beds. He was the first of 3 uncles that lost their lives to addiction and mental health problems. So I ran away from family loss to the East Coast, just as the AIDS epidemic was peaking there. And I took my first job working in the cities of New Jersey with community organizers and also clinical public health professionals who were trying to address the highest rates of HIV infection among women and children in the country. And I was really inspired by people who themselves were extremely sick, but showed up for city hall meetings to speak out for funding for AIDS services at a time when the state was brushing it under the rug, AIDS under the rug. I also saw them stage die-ins and protest to the pricing of pharmaceuticals by the manufacturers that kept them well out of the reach of people with HIV in low-income countries. And I also saw them develop a homegrown form of mutual aid that sticks with me to this day. So the successful community AIDS interventions that I saw were really spearheaded by these people that I just described in combination with socially minded doctors, nurses, therapists, and other workers that were collaborating with community leaders to rethink what a clinic should be. And I realized that AIDS activism really profoundly led to structural changes in medical practice and the way that healthcare and research was organized, mandates for people affected by targeted health conditions to sit on scientific review bodies, community participation in public health campaigns, the gospel of harm reduction to meet people where they are and rather than demand compliance, provide them with what they need to survive. So I thought that at that point, by training in both medicine and social science, I would be able to import the structural intervention that I learned from AIDS activists was so critical into the mainstream of medical care. And I was preoccupied with mainstream medical care because in the US, that's where the financial and capital is concentrated around health, although I knew that that needed to change. And I hope to get back to that concept by the end of my talk and definitely in my discussion with you. So Nancy already gave this really generous introduction about my research, so you got a flavor for what I did after that. I became an addiction psychiatrist, and then in tandem with that, did ethnography of AIDS policy in Cuba, rollout of syringe exchange programs in Connecticut, of Puerto Rican Pentecostal addiction ministries founded and run by self-identified former addicts, of the white opioid epidemic in the US, and my most recent project on ethnic marketing of pharmaceuticals. While I was doing that in medical school and residency, I brought social science and humanities faculty from the college university campus to the medical center in order to have them teach students and residents there. They got a small but devoted following. And I suspected along the way that we needed a language to capture the kind of medicine that we were trying to convey and put into practice, a conceptual framework that would systematize ways in which medicine can be structural. So this quote is really just an indication that I knew, as Nancy has already indicated, that the problem of structural medicine is age-old, and the link between disease, social status, and living conditions has been documented for centuries. So Virchow, the 19th century father of modern pathology, physiology, and social medicine, who's quoted here, he, as you can see, correctly identified medicine as politics. And he wrote just 3 years after Frederick Engels wrote about malnutrition, infectious disease, and opium in the condition of the working class in England. So I'm just kind of putting this in context. This is really nothing new, as we all know. Then a century later, H. Jack Geiger became a figurehead for the 1960s health activist movement by writing prescriptions for food for malnourished black children in the Mississippi Delta. And this is a book that documents a lot of that work. He and many colleagues in the Delta went on to found the network of federally funded community health centers that serve poor communities in rural and urban areas to this day. And in the Mississippi Delta, his health center included a communal farm on which laborers thrown out of plantation work by machines could plant and harvest food for themselves. So this was really taking medicine to another level. He also had a clinic-based educational center that awarded GEDs to largely illiterate population and sent them to graduate and professional schools so that they could get licensed and come back and serve their communities, many of them in the health professions. So they were going for nothing short of political economic restructuring of poor communities that they served. And then I know many of you, because you're active with RadMed and other groups, have read about the Black Panther Party's community healthcare programs that correctly identified health as fundamental social justice. And they were building on a legacy of, for example, historically black hospitals and medical schools that bravely served during Jim Crow. So there's this really long legacy of structural intervention. By the time I entered medical school, however, the country had gone through Reagan. And by the way, I went to Berkeley High, right down the street, and I remember us declaring the airspace over Berkeley High a nuclear-free zone and sending the declaration to Washington, D.C. But this was the era: privatization of healthcare, soaring profits in pharmaceuticals, biotech, and insurance industries, and that made healthcare and pharma, the single largest economic sector in the world. So H. Jack Geiger's community health centers barely survived the slashing of funds for public health care in that period. And the social medicine that was fueled by civil rights movements had been replaced by appeals to cultural competency that, while very well intended and made some gains, in its lowest moments hinged health inequalities on differences in cultural beliefs among patients. So I was being taught an industrial medicine oriented to maximizing profits and minimizing medical legal risk, a medicine preoccupied with diagnostic algorithms, decision trees, and manualized treatments that allowed no room for the lived realities of patients to enter, let alone collaborations with their communities. I was being trained for technical competencies in a Fordist assembly plant style of medicine, and I think that's what accounts for the multiplication of competencies that we were required to master during medical education. Some people bravely pushed back against this with alternative language, such as cultural humility, pediatrician Melanie Turvalon and Jean-Marie Garcia's innovation. Cultural humility called on doctors to level the power imbalance between doctor and patient that was conveyed in the word competence, and instead to foster collaborative relationships with patients and community organizations. But a decade after cultural humility, wanting to further sharpen the focus on institutional and policy change as a part of medical practice, I began work with Jonathan Metzl, Vanderbilt, to popularize the term structural competency. And as Nancy mentioned, it has its advantages and disadvantages. But the idea was to replace culture with structure in the era of cultural competency in order to call attention to political economic inequality as a driver of health outcomes. And to play on the word competency, using it to signal a clinician's responsibility to intervene on institutions and policies. So we thought this language would support a shift in focus from the doctor-patient encounter to levels of disease causation and intervention above the level of individuals. We hope to codify the ethos of causation, the path-breaking work that people like Seth Holmes, Kelly Knight, Jim Casada, and many others were already doing here. There's a concentration of that work here in Berkeley and UCSF, so it's not an accident that we're sitting here. But they're already working on the toxic structures of migrant farm work, sex work, homelessness, and addiction, among many other things. When I talked to clinicians outside of Berkeley and San Francisco, however, people wanted many more specifics. How do you put structure into clinical practice, they were asking. And what are some of the ways people have diagnosed and treated pathological structures on the ground? So I want to do a quick run through of the competencies. Many of you are already familiar with the way that I've formulated it. But this is a four-step approach that I've presented to people in clinical training to materialize structural competency into practice. In clinical training, cases are narrowly framed in terms of individual patient risk factors and choices. So the first step is to teach clinical trainees to read patient presentations against the grain, asking what role neighborhood conditions, institutions, and policies played in producing the injury or disease that made a person into a patient. And then the second step is to help clinical trainees articulate their case in terms of neighborhood, institutional, policy level drivers of their patient's health. And this is what makes structures visible and available for intervention. This is more difficult than it might seem on the surface, but I know many of you are already involved in that. Okay, and then the third step is to get clinical trainees hands-on experience working on structural intervention, preferably outside of the four walls of the clinic. This could take the form of community-based health promotion, work with non-health sector agencies such as schools, law enforcement, or housing agencies, or advocacy for policy change. And then the fourth step is borrowed from Melanie Turvalon and Jean-Marie Garcia. That is structural humility. And Nancy Scheper-Hughes already brought up the importance of humility in this work, particularly among those who've been trained in medicine and engaged in a social contract that medical training was going to give us ultimate power as well. So, and the fantasy that medical training made us omniscient. So, structural humility has at least two meanings. So the first is that trainees acknowledge that clinicians cannot do or know all on their own. that clinicians have to admit to a narrow scope of training and the need to collaborate with community members and people with other types of training like public health, law or policy change, community organizing to effect structural change. And then the second meaning of humility here is that structural change is very slow. It requires patience and celebrating small incremental gains. So this is a stepwise approach to structural competency, at least in clinical training, which is only one area. But it still begs the question, what do these structural interventions look like? So as you heard, there have been 3 structural competency conferences up until now, and I've been involved in organizing those in order to collect cases of structural intervention to answer the question I just laid on the table. What do they look like? We've had, in addition to these meetings, 2 webinar series, one hosted by the American Medical Students Association, the other by the State University of New York. And we've published cases in 2 special journal issues on structural competency. Among the contributors, many of the people in this room today. They're coming out in Academic Medicine, and there's one already in Journal of Bioethical Inquiry. I've also worked on, and I'm going to talk about this later, structural competency projects with clinical residents and students at NYU. So I want to categorize these interventions, the cases that I've collected, into 4 levels of structure upon which they're acting. Okay, the first one is low-hanging fruit, and it's the most intuitive to people who've been trained in clinical practice. And that is things that you can do to restructure care within the clinic, within the 4 walls. So examples include incorporating prompts to ask about social determinants of health into electronic medical records. And UCSF researchers Nancy Adler and Laura Gottlieb have really pioneered that and have showed that it really does influence treatment plans and referrals for social services. Another example with evidence of impact on health outcomes is medical legal partnerships. These partnerships pair clinical trainees with law students or pro bono lawyers to work to defend patients' rights. For example, pediatric clinics can force landlords to comply with lead decontamination laws. Schools can be forced to provide appropriate support for learning disabled children. And in my area, psychiatry, we can prevent the eviction of patients who are suffering acutely from symptoms and are too decompensated to pay their rent. And then the last on this list is Health Leads, which was formed by Rebecca O'Neill while she was still a pre-med student. It places student volunteers in clinics to fill prescriptions, quote unquote, kind of in the mode of Jack Geiger, actually, to help patients navigate the housing system, disability applications, and the like. So the next level of structure upon which we can intervene, and here I'm still thinking in terms of clinical trainees, and I want to get beyond that, but this is an example of a community partnership, getting trainees outside of the 4 walls of the clinic and engaging them with community. So that requires them not only to leave the clinic, but also to learn about the neighborhoods in which their patients live and find ways of making themselves useful to potential partners there. I'll give you an example of the psychiatry elective that I started at NYU in 2012. I was approached by the Brownsville Partnership, which is a collective of 27 social service agencies, community-based organizations, and churches, probation officers, et cetera. They were coming together to address housing instability and the need for community development in Brownsville, Brooklyn, a neighborhood which has the highest density of public housing in the country, and which has among the highest rates of unemployment, incarceration, and psychiatric hospitalization in the city. The Brownsville Partnership sought our help because they noticed that a lot of their residents, community residents, were not able to take advantage of the programs they created because of mental health struggles. Okay, so residents took a 1.5-hour train and bus ride to this transportation desert in East Brooklyn and began home visits with people in danger of eviction, doing mental health needs assessments and multidisciplinary teamwork along with social workers. They then undertook a community mental health needs assessment in which they interviewed residents, clergy, social service agency staff, police, probation officers, and more, getting information about the high levels of community violence and trauma in the neighborhood, about mistrust of clinics and hospitals in the neighborhood, actually slightly outside of the neighborhood because it's also a health service desert. But the closest clinics and hospitals had staff that were more than ready to call Child Protective Services and to involuntarily hospitalize patients, among other things. We also identified high levels of staff burnout at local CBOs and service agencies as a big problem. And this informed plans for a community wellness center that the Brownsville Partnership built there 2 years ago. Based on the needs assessment that the residents did along with Brownsville Partnership staff, they trained local residents to run peer support groups for survivors of trauma. They enhanced communication with probation officers, which began to lead to early identification of mental health decompensation and treatment for clients who otherwise might have faced rearrest or rehospitalization. And then lastly, the residents are still working on hotspot mapping of emergency room data to identify housing units for targeted preventive care. All right, so the next level of structural intervention is cross-sector collaborations. And you'll see here a photo of Mindy Fully-Love. She is my favorite example of someone who works with sectors that aren't identified as health sectors, but nonetheless have a significant impact. She's a psychiatrist who no longer treats individual patients, but rather sees cities as her patients and objects of diagnosis and treatment. Her early research was on the health impact of government-sanctioned racial segregation and displacement in the form of redlining of mortgages. This is a redlining map of Philadelphia, urban renewal and planned shrinkage. That she documented with colleagues led to HIV transmission and a host of other health and mental health problems as community networks were shredded by serial displacement from these neighborhoods. She's now collaborating with urban planners and architects in places like Pittsburgh, Pennsylvania, and Orange, New Jersey to redesign cities, to residentially reintegrate them by race and class, and to create integrating public space. Okay, here's in the fourth level. This is a slide to give you a hint as to which policy concerns I've been preoccupied with recently, but it's only one example. So policy is an area that clinicians feel especially unprepared to enter. You know, as I talk through structural competency with trainees, policy, that's an alarming, overwhelming thought. But what I tell them is that they, as clinicians, hold significant symbolic capital to make their voices heard, because often it's not justified, but often when a clinician speaks up and identifies something as a health issue, people listen. They're just sort of trained to listen to doctors or to clinicians. As an ethnographer of addiction and a psychiatrist, as I said, I am preoccupied with the inequity and loss of life created by the war on drugs. So over the past few years, I've been getting residents, medical students, and faculty from the medical school involved in a New York-based group called From Punishment to Public Health. This is a group that was founded by clinicians, public health practitioners, and disenchanted law enforcement officials, along with formerly incarcerated people. One of their major activities is to train their members to testify to the state assembly and state politicians about the impact of Rockefeller drug laws on people in communities of color experiencing mass incarceration. They complement this level of policy advocacy with programs to divert people from arrest to mental health treatment. For example, they created a mental health unit on the subway to which police now bring people for assessment before deciding to arrest. So these are examples meant to inspire and incite creative local problem solving, because structural competency is going to look very different depending on where you are, what the local issues are, and who you have to partner with. But I also have to say I came upon another realization much too late in the game. After touring medical schools, I started to get some invitations from public health and law students to speak about structural competency, and I realized that following my own principles, structural change won't go anywhere if clinicians are trying to do it alone from within medical schools. Structural competency training itself demands interdisciplinarity, which requires joint or complementary training for public health practitioners, lawyers, activists, and community organizers with which clinicians collaborate. And then second, not having trained myself formally in public health, law, or community organizing, I and my clinical colleagues really do not know how to do this in these other fields. The other thing that I realized was that what we really need to foster under the heading of structural competency is really the inverse of Mindy Fullilove. Not only doctors who become urban planners, but urban planners as well as lawyers and community organizers who act as doctors with regard to treating the systemic pathologies of our cities and our country. So this is a problem I'm going to pose to you. This is a group of accomplished interdisciplinary people working in structural competency who are demonstrating what it looks like. How do you translate structural competency into your field? And what are the opportunities for cross or joint training with clinicians that you could imagine or create, if indeed you think that that would be useful? But before I ask you to answer that question, I want to reflect on enemies and weapons of structural competency that implicate, and I see I have 5 minutes, so I'll go through quickly. Enemies and weapons of structural competency that implicate us all. Because the call to structural intervention is really a battle cry, right? There are reasons why structure is so invisible within our healthcare system and so not amenable to change. At the same time that economic and health inequalities are deepening in the country. So this is not going to be easy. All right, so I hope I don't offend anyone here, or maybe I will offend someone and that'll be productive. But here is one of my current pet peeves. I think that implicit bias testing in clinical training has begun to replace cultural competency, take the place where cultural competency once sat. Because instead of locating the cause of health inequalities in cultural beliefs and behaviors of individual patients, we're now in clinical training locating it in the beliefs and behaviors of individual clinicians. Implicit bias, seemingly something that all of us can agree should be eradicated, nonetheless can take the focus off of structural racism and structural levels of causation. Okay, so here's another one that some of the public health researchers in the room may take me to task for, but it's evidence-based medicine. Medicine is really an anti-politics machine. You know, the political consciousness of the practice that we're doing is sucked right out during our training. Medical institutions jealously guard the boundaries of legitimate clinical language, demanding objective diagnoses and evidence-based treatments that are overdetermined by randomized controlled trials that control for the very structures and inequalities that we're interested in. How can we address structural racism by eliminating race from our analysis in this fantasy of finding universal health indicators and approaches? Okay, and so here's another one, health industries, and it's probably the most overwhelming. The conservatism of medicine is certainly the product of the mass industrialization of healthcare, and I'm thinking of pharma, biotech, insurance. Let's not forget that these industries are highly profitable and were major engines in the recent concentration of wealth in our country. Let's not get complacent with health reform and its lofty language of population health and accessible community care, because in the end, insurance companies and pharma are still getting large payments from a growing pool of insured people who are paying higher and higher premiums, and the privatization of Medicaid means that they're getting extra tax dollars as well. The system is still market-driven, and managed care companies still offload responsibility for expensive patients. Okay, so to this collection, I want to add pessimism, demoralization, and burnout in the face of really overwhelming trends. Doctors, for example, are dropping out of clinical practice in record numbers, citing structural factors like brief office visits and limited contact with patients and their communities, unsatisfying contact and poor treatment outcomes. As a Robert Wood Johnson-sponsored national survey of doctors found, 80% of them said they saw social factors as getting in the way of their patients' health, but none of them knew what to do about it. Okay, the good news. We have a few weapons. The first is the emergence of population health studies of structural sources of health inequality in public discourse. And I want to shout out to Bruce Link in the audience. His theory of fundamental cause of disease is gaining wide circulation. Recent reports such as this one by the Institute of Medicine showing that the US falls below its 17 peer countries in terms of health outcomes despite paying more than these countries for health care, highlight structural factors as responsible for our costly and pathological system. And then you may have seen images, whoops, okay, this one. Images like this one from epidemiologists Richard Wilkinson and Kate Pickett showing a linear relationship between economic inequality and population health outcomes, which the US claims to be on top by both measures, the most economic inequality and the worst health outcomes. All right, so now let me go back to this image. The second is the rise of social theory that denaturalizes inequality and tracks it, how it's produced. Thanks to critical race theory, we speak in terms of institutional racism and colorblind ideologies that, by banishing race from politics, attribute mass incarceration, unemployment, and school failure to individual choice. Other examples are feminist analyses of medicine, critiques of global capital that evades local regulation of biotech and organ trade, as Nancy Scheper-Hughes has so brilliantly documented. The concept of structural violence has definitely been taken up into health activism, and biocultural understandings of the interaction of bodies with their environment as outlined in theories like Nancy Krieger's ecosocial theory, how racism and discrimination get under the skin. All right, so this image may look familiar to some of you because it's actually from UCSF. And it's really meant to represent anger and community mobilization around police violence in black and brown neighborhoods as a window of opportunity for structural change. White Coats for Black Lives has gotten medical schools to focus on structural conditions of race violence, and it's given a cohort of students experience in organizing themselves and working with community organizations. This is happening in New York City too, so it's really heartening, and it's also being picked up in the middle of the country in certain places. So these groups are repoliticizing medicine, which is an important aim. All right, and then speaking of aims, there may be a silver lining to the health reform discourse of value-based reimbursement that requires clinics to track patient outcomes on a population level and also incentivizes managed care companies to provide social services that are known to improve health outcomes, such as Medicaid-sponsored housing subsidies. These mandates are helping to entrain health providers and health administrators, as well as the voting public, to recognize social intervention as less costly than medical intervention. And I'm hoping that it'll lay the groundwork for deprivatizing healthcare and a renewed investment in public benefits. This is kind of my favorite topic, but I have to rush through it. It's an image from the Sobriety Garden at Bellevue Hospital where I work, and I've talked to many of you about the fact that spending time in this clinic that has a garden, that has creative arts therapies, that makes film with patients and staff, that hosts a whole range of celebrations and community events, that's something that keeps me going. And what I like about the clinic is the emphasis on mutual aid and the blurring of the distinction between community and clinic. It's essentially creating a community within the clinic for people who, for the most part in this clinic, come from homeless shelters and have lost contact with their families. But this is also a positive aspect of health reform, at least in New York, that peer mental health work and community health workers are now eligible for reimbursement, and that could go, if done properly, a distance in blurring the distinction between community and clinic, staff and community. I'm not going to go into detail about global health, except for to say that I was very skeptical in the beginning of potentially medical tourism. But there has been, my colleagues at Yale and other other medical schools have documented that those who go to low-income countries and have proper background in the institutional structural conditions, creating what they see, come back more sensitized to structure in the US. So that brings me back to my question for you. How can we work in tandem together across disciplines for structural change? And which enemies and weapons in the battle for structural change would you add to the list? Thank you.